Yeah, good morning, everybody. So since the treatment, both medical and surgical, has been taken care of, I'll just rush through the points that are relevant to in a patient that has both cataract and diabetic retinopathy that is significant. Now, cataract surgery is not as straightforward in a diabetic population as it is in the other general population. Cataract is known to cause the progression of retinopathy and a progression of maculopathy. It is known to induce maculopathy in those eyes that have retinopathy but no maculopathy. And there are studies that have shown that almost it doubles the incidence and the progression of the diabetic retinopathy in patients that have had cataract surgery. Remember, these are all Western studies that have been done in patients who have fairly well-controlled diabetes and who have their systemic status very well under control. So, in our setup, where we routinely see patients with 7, 8, 9 percentage of glycosylated hemoglobin, we probably are at a much higher risk. Now, the other thing that we need to understand is that when you have a preoperative macular edema in a patient with diabetic retinopathy and macular edema and a cataract, if you don't treat the macular edema and go ahead and do the cataract surgery, the macular edema later on is a little more tough to handle. It does not go away that easily. Post-cataract surgery CME developing in a patient who has no macular edema prior to the surgery is relatively easier to handle. So let's look at how we go about it. So we all know that diabetic retinopathy presenting in a patient with cataract can either be non-proliferative or it can be proliferative. Now, in the non-proliferative stage, you can either have a patient who has a macular thickening or who does not have a macular thickening. So, and each of this can again be divided as having an early or a very early cataract, not very significant, and having a significant cataract. So we'll look at how we treat each of these differently. Now, a patient of diabetic retinopathy who has a non-proliferative diabetic retinopathy, not a significant macular edema, and who does not have a very significant cataract, only an early cataract, you'd probably be best we do best observing them. If the patient has a significant cataract, you can go ahead with good quality phacoemulsification or good quality cataract surgery. Of course, you have to explain to the patient that there is an increased risk of CME vis-a-vis the normal population, which is the rates are in the range of about 40 to 50%. You have a risk of progression of DR. In cases who have severe NPDR, they may progress to PDR. To prevent the CME, to prevent the occurrence of CME, you can use pre-op NSAIDs, you can use subtenon and tricot along with your surgery, but again you have to warn the patient. Now, what if the patient has a CSME and has an early cataract? Now, the first thing, the preferable thing to do is not to hurry up with your cataract surgery, it is to treat the CSME, get your macula dry, and then consider cataract surgery. And at the time of cataract surgery, even if there is no macular edema, consider an anti-VEGF agent. Now, there are studies that have shown that if you give an anti-VEGF agent at the time of cataract surgery, the post-cataract rise in macular thickness does not happen. Also, you need to have a low threshold for steroids, because here already a cataract has started. You are not inducing a complication. One of the complications of steroids is cataract induction. Now, when you have an NPDR with CSME and you have a significant cataract, of course you have to handle the cataract, but then if possible, it's always better to treat the CSME first. Now that we are relying less and less on lasers and more and more anti-VEGF injections can very well be, or steroid injection, these can very well be given in a case with cataract. You don't require a perfect, crisp, clear visualization of the posterior pole. So treat that first where possible. If the cataract is very severe, then you can go ahead with a phaco along with an anti-VEGF agent or a steroid agent as you would choose. And the phaco, but I would recommend that you do it after CSME control. Now, there was a talk where the point was raised of doing FFAs. Whenever you are in doubt, when the fundus visualization is not very crisp because of the cataract, always I tend to err on the side of over-investigation and make sure what I am dealing with. A lot of times, small fronds of NVE may be missed. A lot of times, macular edema may be missed. So it's better to do an FFA, to do an OCT, to make sure what you are dealing with, and then go ahead and plan your further intervention. A lot of times, you would think that there is a PDR when actually you have only collaterals or irmas. Now let's come to the other situation where the patient has PDR. Now PDR, if there is no CSME, or PDR who has CSME, and of course whether you have an early cataract or a significant cataract. So we will see what you do. If you have PDR, you have no CSME and it's an early cataract, it will allow panretinal photocoagulation, and that is the treatment of choice. If you want to do a phaco, it's best to do it 3 to 4 months after you have completed your PRP. Now if there is significant cataract that does not allow your PRP, you can still do a little bit in the periphery to the extent possible, and then follow it up with a phaco. If the cataract is very dense, go ahead with the phaco. Some people use intraoperative laser indirect ophthalmoscopic LIO PRP. Some people do it 3 to 4 days after the cataract surgery. But the point is that you need to get the PRP in place for any PDR. Would you use an anti-VEGF agent? Yes, if the polyps are flat, if they are not raised, if there is no traction, intraoperatively you can use an anti-VEGF agent to give you a window of opportunity to complete your PRP, but then again that's a temporary measure. What if there is PDR with CSME and with an early cataract? Of course, you investigate the patient for macular ischemia, you rule out VMT, because this will take you to a totally different way of approach. If VMT is ruled out, you would probably do PRP along with an anti-VEGF agent or steroids, handle the PDR, handle the CSME, and then go after the cataract, not the other way around. In cases where the cataract is significant and does not allow you to handle the PDR component and the CSME component, you can do phaco along with an anti-VEGF under guarded prognosis. Now these cases have a high risk of PDR cases undergoing cataract surgery have a higher risk of NVG or neovascular glaucoma and neovascularization of the anterior segment. Now when you are doing cataract surgery, what are the things that you need to take care of? You need a good quality cataract surgery. You have to avoid the complications of disturbing the posterior capsule and the anterior hyaloid. You have to remember that a lot of these patients don't have very well dilating pupils. You may have a leathery cataract. The rexus needs to be large, and you need to do whatever you can to prevent PCO. Silicone IOLs are anyway on the way out. You prefer a hydrophobic or a hydrophilic IOL. Small optics need to be avoided, preferable to put in a 6.5 mm optic. The difference in visualization is almost 35% when you compare a 5.5 to a 6.5 mm optic. Single piece and especially plate haptic lenses are best avoided. Multifocal lenses are used with caution. If a patient has PDR or a very severe NPDR, I would not recommend, or I would go against a multifocal lens, because this makes future PRP a little more difficult. A closer monitoring is required than with a routine cataract patient, because these patients are at a fairly high risk, almost a 6 to 7 time risk of development of macular edema and a progression of their.
Abhishek, can we wrap up first?
Yeah, you're done. Thank you.